Good afternoon, everybody. Welcome to this webinar, which is, can we just go to the previous slide for a moment, please, Sarah? We're on just 12 o'clock. No, previous slide, please. This is one of a series of webinars, which previous recordings are on the internet on our website. And this is being delivered Health Innovation North East North Cumbria and Health Innovation Yorkshire and Humber. This is webinar 3 of this particular series, and we are covering obesity, fatty liver disease and diabetes. Next slide, please. My name is Jane Skinner. I'm a strategic advisor for cardiovascular disease with Health Innovation North East North Cumbria, and I'm delighted to be introducing this webinar today. We have, as usual, our 2 excellent speakers, and I can't speak highly enough of them. I feel very privileged to be able to chair the session with them. A couple of housekeeping things. Please ensure your microphone and video are turned off during the session to avoid any disruption. If you need to take a break, by all means, feel free to drop off and rejoin. The event is being recorded and will be shared, which will, of course, include the slides. And if you've got any questions, can you put them in the chat facility, please? If we've got time, we will cover them during the event. But if we don't manage to do this, then we'll follow up after the event. And we may cover them verbally, but we may equally have responses put through the chat system as well. So keep an eye on that if you've posed a question or want to see the answer to a previous one. This is just about health innovation networks. We'll move on. So our speakers today, we've got Dr. Rani Kateb, who is going to speak first, and then Helena Gregory. Rani, I'm very pleased to be able to introduce. He's a specialty consultant pharmacist in cardiology and cardiovascular clinical research at Leeds Teaching Hospitals NHS Trust, and has both a local, national and international portfolio of activities, and has had multiple recognitions and awards for innovation and excellence in patient care. Both he and Helena are frontline clinicians. They know what it's like to see patients and spend a lot of time doing that as well. We are very, very grateful that they've both freed up time today to come and join us for this webinar. So I'll hand over to Rani, who is going to talk first, and then Helena will follow on from there. So Rani, over to you.
Thank you, Jen. Just sharing the slides. Right, thanks everyone for attending this session. This is webinar 3 from our series, Living with Multiple Chronic Conditions. And today we're going to cover obesity, non-alcoholic fatty liver disease, or what is called now MASLD, and diabetes. And just to give you a heads up, it's going to be quite challenging to cover these big topics in an hour between us, and therefore we're going to be giving you kind of highlights with regards to these conditions. We'll be exploring obesity, diabetes and MASLD and the management, and try and help you appreciate the interplay between these conditions, given that the series is all about living with multiple chronic conditions, and these definitely some of the metabolic conditions that usually have a huge interplay, one leading to the other, complicating another, I guess. We've already talked about these slides before, about how the burden of cardiovascular disease globally as the cause of death. We talked about the different chronic conditions and how they contribute to the majority of the burden of death that we have. And we talked about the risk factors that leading to death. And you can see that obesity is very high up there, and also high blood sugars is very high up there. So the focus today will be around that, and also the interplay between them. The CKM concept is all about the whole idea in relation to the interplay between the cardiorenal metabolic And it's interesting, if you look at this CKM concept from the American Heart Association, it starts with the adipose tissue, and the adipose tissue representing obesity, and how obesity leads to multiple complications, which all also kind of interplay. So you've got the formation of the non-alcoholic fatty liver disease, and you've got also, of course, the interaction with the formation of diabetes or developing diabetes and metabolic syndrome. All this cascade leading to a lot of inflammation and oxidative stress, leading to other complications which impact on our kidneys and the heart as well. So so you can see here that the start of the whole of the CKM syndrome seems to rotate around adipose tissue, and how adiposity is quite important driver of the CKM syndrome as a whole. And that's where the focus on obesity is quite important in the considering of the cardiorenal metabolic interplay. Another thing I wanted to highlight is the triad that you see between obesity, type 2 diabetes, and cardiovascular disease. Type 2 diabetes is a risk factor for cardiovascular disease. Obesity is one of the major causes of type 2 diabetes, and obesity also is a CVD risk factor. In fact, now it is seen and listed as one of the risk factors that needs modifying to reduce the burden of cardiovascular disease. MASLD, or what we call now, or what we used to be called non-alcoholic fatty liver disease, is the metabolic dysfunction associated steatotic liver disease. Basically, it is the buildup of fatty deposits within the liver, but it is the underlying cause, the metabolic underlying cause, which is quite important, because it's the insulin resistance, is the lipotoxicity, is the high levels of inflammation that indicates that there is something going on wrong with the liver. Liver presents it as having fatty deposits, but it means there's a lot of inflammation going on in the body, and that, of course, has an impact on the heart, developing multiple cardiovascular conditions, but also is a driver of cancers. And a lot of cancers seem to be having MASH or having MASLD seems to be have a huge association with different cancers. So that's important to remember. And of course, one of the things that MASLD develops to be is developing the carcinoma in the liver itself, which usually tend to be one of the end complications of MASH, which we'll talk about later on. But as you can see, the interplay here is all dependent about all the inflammation, the lipotoxicity, the adiposity that is going on in the system, leading to all the interplay of developing all these different conditions. So starting with obesity as an introduction, first of all, kind of, if you want to define obesity, is a multifactorial. It's not just somebody eats too much, it's a bit more than that. It's chronic, it's relapsing condition. It has an abnormal, excessive accumulation of body fat, and it's a huge risk for health, and we will talk about that. It's very important that obesity to remember that obesity acts as a gateway to a range of other complicated conditions, chronic conditions that we're going to talk about. If you want to look at technicality of it, usually we try to identify people who've got obesity by looking at the BMI, the body mass index. It's just a pragmatic way of identifying if somebody is actually overweight or obese. And there are limitations for it, but generally speaking, if somebody is over 25 or over of a BMI, that's overweight. If somebody's hitting 30 and above of a BMI, that's obese. However, it's really important to take into consideration when handling BMI. Number one, that it is different to other ethnicities. So, for example, Asian ethnicities might require you to lower the definition of overweight and obesity by a certain amount. And I intentionally included a breakdown of some Asian population to just tell you we have the tendency of lumping everybody together. So when you talk about the Asian population, you just think like all Asians are the same. It's not true. And this is an interesting, that's from the ESC guidelines, showing how the cutoff point for the Korean, Japanese, and Chinese could be slightly different. That's within the same population. So it's just to show you some of the limitation of interpreting BMI. The other element to remember is that and caution when interpreting BMI is that the use of weights, the waist to height ratio, so measuring the circumference, the waist circumference is quite important to actually try and understand central adiposity, because central adiposity is very important when it comes to the complications of obesity. Therefore, when you're trying to estimate people's risk and cardiovascular risk or the risk of developing diabetes, you need to do a little bit more around that. The talk is beyond the scope of me detailing this, but I just wanted to highlight it. Of course, this is just, I've got some loads of slides about, I'm not going to dwell into them, but like adiposity is a driver of inflammation. Adiposity is a driver of lipotoxicity. Adiposity is a driver of activation of other systems in the body, such as the sympathetic nervous system, such as the renin-angiotensin, aldosterone system, and all these will lead to the different conditions that you are seeing there. So adiposity is quite has a huge consequences on the body, and that's why there is a huge interplay between an association with many conditions. I'm not going to dwell into the detail of it, but it goes not just cardiovascular. You've got the cardiovascular element, so you see more strokes. You've got heart failure, especially preserved ejection fraction, but you've got arrhythmias, AF. The association between adiposity and AF is so significant that the ASC guidelines clearly recommends, and there's a lot of studies showing that losing weight reduces your risk of developing AF, but also if you have AF, it can help actually resolve AF as well. But this is in addition to other risk factors such as cancers, osteoarthritis, and then osteoporosis, etc. All these different conditions are affected by adiposity. So while explaining this, so the diagram on the left is just showing a lot of this interplay and how adiposity seems to affect different organs, leading to a lot of cardiovascular risk and complications. The one on the right is trying to tell you that basically adiposity and obesity is not simply just increase in calories and reduce in expenditure, which is one factor, but there are other factors. So there's genetic predisposition to obesity, there is neurobiological factors, there is socioeconomical status and psychological factors. So quite a complex reasons why people could develop obesity, and that's very important to remember when we are dealing with patients and are trying to advise them and help them tackling obesity. And of course, the burden of all this on the cardiovascular disease is massive, as you can see, huge association with all different types of cardiovascular disease as highlighted there. And diabetes, of course, in specific. This is a study where it says basically of what kind of association with different cardiovascular conditions, and a 1 kilogram per meter square increase in BMI on cardiovascular conditions. And you can see basically it's showing you odds ratios, which are showing just one shift in a BMI has quite a huge impact on the likelihood of somebody developing all these different cardiovascular conditions. And we have a problem globally. So globally, we're talking about globesity, basically because we're talking about obesity is taking over the world. Well, it's estimated that by 2030, about 38% of the world's adult population will be overweight, another 20% will be obese. And that's huge. And we're talking about a billion, as you will see later on. Another fact I wanted to highlight is that obesity is not something that we need to talk about with regards to adults only, but starts with childhood. And in England, for example, it shows that out of 100 children, you're talking about 15 are obese and 12 are overweight. And obesity and being overweight at a younger age is associated with a higher risk of diabetes and cardiovascular disease at a later age. And that's very important to remember. If you want to look at association with death, like nearly 70% of deaths related to high BMI are attributed to cardiovascular disease. So most people, 70% of people with high BMI die from cardiovascular disease, then cancers, and then other complications such as CKD and diabetes. And what's interesting is that all-cause death is increased by nearly 30% for every 5 kilogram per meter square increase in BMI above 25 kilograms per meter square. So there's huge amount of risk for increasing it. So the key messages from here is that we've got a huge burden of obesity globally. It is not just in adults, but it's growing also in children. We need to tackle it, and we need to do something about it at a population health level, because the consequences are tremendous, and the interplay between it and developing other chronic conditions is actually quite important. The benefits of losing weight, well, depends how much you lose. As you can see, if you lose only 5% of your weight, your blood pressure goes down. Blood pressure is a high driver of cardiovascular risk, and your glycemia get better. If you go to 5 to 10%, your fatty liver gets better, your dyslipidemia gets better. You're likely to start probably reversing some type 2 diabetes. If you go higher and higher, so for higher percentages, you're likely to drive even more. If you're hitting 15% or more, if you've got heart failure with preserved ejection fraction, you're likely to improve your heart failure. You're likely to get type 2 diabetes remission if you have 15% or more reduction. So that's why obesity is a big thing, because of the interplay and the benefit gained from losing weight. Now, I'm not going to go into the detail, but this is a nice guideline recommended approach for managing overweight and obesity. And it tells you about the journey and what the consideration you need to think about, and how it includes diet, behavioral support, medicine, surgery, psychological support, physical activity. I won't dwell into that, but I wanted to highlight it as a document that's available on the NICE website. The ESC guidelines also talks about that. Lifestyle interventions probably do not necessarily lead huge amount of weight loss. So you can get probably about 3 to 10% of weight loss if you look at dietary changes. Physical activity is not as effective, but it's actually good for weight loss maintenance. And then you've got different levels of weight reduction benefits that you get from the different types of pharmacological drugs you use, tirzepatide being the highest, and of course bariatric surgery is much higher. But it's remember that when you're managing weight and weight loss, that the objective is not just losing weight. But you need to remember that when you're managing obesity, you are also need to be thinking about prevention, resolution or improvement of obesity-related complications, the quality of life, mental health and well-being, and improvement of physical and social functioning. So these are very important to remember, and not just focus on just weight loss. There's a lot of literature, and confusing literature, but diet, and the scope of this discussion here today is beyond me addressing this. This is some of the highlights from the ESC guidelines about dietary things that might be helpful in terms of weight loss. I won't dwell into it because it's a big discussion. In terms of exercise, the only thing I wanted to highlight, something that was presented at the AC Preventive Cardiology Congress that I've been to recently, is that there is a difference between exercise for your cardiovascular health and exercise to maintain weight loss. So there's a slight difference between the regimen, if you like. So maintaining weight maintenance require a high volume aerobic exercise of at least 200 to 300 minutes a week of moderate exercise. So you need to kind of remember the slight difference between the two. These are the different drugs that come and gone. The red ones are discontinued. The main ones we're going to just talk about and touch on are tirzepatide, semaglutide. Liraglutide is not as much because it's not as effective, and orlistat has fell out of but it's mentioned by the NICE guidelines. So these are the ones listed in our national guidance. So liraglutide, semaglutide, tirzepatide, and orlistat. And there are different requirements and cutoffs for the BMI in the presence and the absence of other obesity-related morbidities in order to allow the prescribing of these medicines. So that's kind of detailed, and you can easily find it, but this is kind of a highlight. The most common is tirzepatide. I'll detail it a little bit more. Tirzepatide has got the highest weight reduction benefit that you can see, but these also drugs, don't forget, especially the first three, are actually used for diabetes as well, and they've got some benefit in the management of MASLD as well. There are overall consideration that NICE highlights again, and I'm not going to dwell into them, but they are important principles of care that you need to remember when you're managing people who have got obesity, because a lot of these highlights are really, really essential to remember and what to take into account and understanding how people feel. Just jumping to diabetes. It's another metabolic condition. Diabetes, at the end of the day, is a metabolic condition, which basically presents as high level of glucose. So you've got high levels of glucose in your blood. It is symptomatic, but not always symptomatic, especially type 2 diabetes. These are the different symptoms you're likely to get, but 40% of adults worldwide are not diagnosed with, despite being diabetic or not being diagnosed, because in most cases it's asymptomatic. And it's important to think that probably any abnormal glucose metabolism has an important consideration. And that's why there's a growing research into the pre-diabetes region, because that's also a risk factor for developing cardiovascular disease and progressing to having multiple chronic conditions. It's another a global problem affecting 10% of the world population, and this is expected to rise to nearly 780 million cases by 2045. So this is kind of UK figures. There's about 5.5 million people with diabetes. The ones who are diagnosed are probably 3.4 million, but there are 12 million who are at increased risk of developing diabetes. Obesity is definitely a driver of diabetes, and there are different prevalence among ethnicities, so that should be taken into account when we are risk assessing and managing people of different ethnicities. The burden of diabetes is huge, and if you if you suspect somebody to have diabetes, or when you're assessing somebody who's at risk of diabetes, then the diagnosis guidelines are out there, but the simplest is HbA1c. You need to have at least 2 HbA1c readings. If they are 48 or above, then that indicates that the person has diabetes. If it is the pre-diabetes, it will be somewhere between 42 and 47. I'm not going to dwell into the detail of that, but the diagnosis is important to identify pre-diabetes and diabetes when we're managing patients. Once you've identified that somebody's got diabetes, the next step is to know which type, because that impacts on what kind of therapy you're going to be offering. I'm not going to detail the different types. The main two ones we know about is type 2 and type 1, and the most prevalent is type 2. There are other types of diabetes, but it's beyond the scope of this talk. Type 2 diabetes constitutes nearly 90% of diabetes population, and this is the one that we're going to be focusing a little bit more about. But type 1, of course, needs insulin because there is complete loss, destruction of the beta cells in the pancreas, whereas type 2 is slightly different. There is an element of resistance or reduction in the insulin secretion. When we talk about diabetes, when you talk about the complications of diabetes, there are traditional complications such as diabetic kidney disease, a huge association with CKD in diabetes, but of course increased risk of cardiovascular disease, heart failure, you're at higher risk of having heart failure, peripheral neuropathy, and of course there are emerging complications also. For somebody who's got diabetes, a higher risk of cancer, also liver disease and MASH. We'll talk about MASLD and MASH, and also cognitive disability and other complications. This is a list here giving you all the different examples, but I just wanted to give you a feel. Like, for example, 25% of patients with type 2 diabetes is going to develop CKD. You've got the diabetic eye disease. It's a leading cause of blindness. 30% of patients will have some ocular problems at the time of diagnosis of diabetes. If you have got diabetes, you are 2 to 4 times more likely to develop heart failure as it progresses. And you've got the diabetic foot ulcer complication to report in about 10% of patients. That's why the management of diabetes is beyond just controlling hyperglycemia. It is about reducing the risk of the development of all these complications, and that's why we have annual screening, for example, retinal screening, examining the foot, diabetic foot clinics, in order to reduce the risk of developing all these complications. And if they develop that, we pick them up early on and we manage them. Now, the driver of a lot of these complications And additional complications are, in essence, four factors: inflammation, insulin resistance, and high levels of insulin circulating in the body, hyperglycemia, and hypoglycemia. And each one of those, as you can see in this diagram, drives different elements. Like, you've got insulin resistance, a huge driver of developing of the fatty liver disease, huge driver, and insulin and inflammation as well, and to some extent hyperglycemia, but not as much. And then you've got a variety of cancers that you're more likely to develop. You've got diabetes, and of course, not to forget, frailty and sarcopenia is something that is also seen due to the inflammation and the insulin resistance that we have. And many patients have got diabetes, the higher risk of frailty, and nearly 18% of those have sarcopenia. Now, managing diabetes requires holistic care. I like this diagram because you've got the goals of care here, talking about all different elements to think about. But because people have got diabetes, they're at risk of developing all these other conditions. The management goes beyond just glycemic management. So we no longer just talk about glycemic management. We talk about glycemic management because most of these people have got weight problems, that we're talking about weight maintenance. And then we talk about cardiovascular risk because people with diabetes have got high levels of cardiovascular disease. And then, of course, the favoring of the prescribing of medicines which work for both diabetes and reduce the risk of CKD, or treat CKD, or reduce progression of CKD, and also are of benefit to heart failure. I'm not going to go into the therapy in detail, but we know that we are moving from just being focused on managing glycemia to actually adding drugs such as SGLT2 inhibitors and GLP-1 agonists, which are quite important. I know the NICE guidance is not as liberal in recommending GLP-1 agonists in the use of diabetes, except those who have a higher BMI, but the ASC guidelines is quite blatant about using SGLT2 inhibitors and GLP-1 agonists high up with people who are living with cardiovascular disease and diabetes, or at high risk of developing cardiovascular disease. And that's kind of slightly different between the NICE and the ASC guidelines, but the rest of the drugs are the usual. And as I said, I'm not going to dwell on it too much. For type 1 diabetes, of course, you all know about the importance of the continuous glucose monitors, and they were found to be very helpful and useful in better controlling diabetes with insulin in type 1, and they've got benefit in type 2 as well. But we don't want hypoglycemia as well, because hypoglycemia has terrible consequences, whether it is inflammation, whether it is cognitive effects. So the same way we don't want hyperglycemia, we don't want hypoglycemia as well. So it's important to do that for both. To finish off with metabolic dysfunction, the term shifted from non-alcoholic fatty liver disease. Apparently, the new term, metabolic dysfunction, is to increase awareness of the condition, to improve patient identification, and to reduce stigma. And basically, it's trying to say that fatty liver disease is a metabolic condition, it's not a liver condition. It's trying to tell you that the liver is becoming fatty because something else is going on that making it become fatty. And that's why, to be diagnosed with MASLD, you need to have fatty liver, but you have also at least one cardiometabolic risk factor, which is listed here. So having these cardiometabolic risk factors along a fatty liver, that indicates that you've got the condition of MASLD, which is associated with cardiovascular disease and other complications. So the idea here is that in order to make us think about fatty liver as more than just a little bit fat deposits in the liver, and hence the change of the name. It's a metabolic problem. Something is going wrong seriously here, and that's why it's a metabolic problem. And you need to think about it as such. Of course, MASLD progresses, and when it progresses, it becomes metabolic dysfunction associated steatohepatitis. So you're going into hepatitis, and hepatitis is actually quite serious, because then you've got inflammation and risk of fibrosis, and of course cirrhosis and progression to carcinoma, hepatocellular carcinoma. So that's very important to remember why fatty liver is important. And here's a story while you're reading the above. So you've got normal liver, about 25% can end up developing MASLD, which is just isolated fatty liver deposits. But then 20% to 25% of those can progress to develop MASH, where you have inflammation now. You've got some without any fibrosis, but you've got others who develop fibrosis and cirrhosis and hepatocarcinoma later on. So it starts with trying to tell you that there is something wrong going on metabolically in your body. You need to sort it out. And then it goes on to develop into MASH, and then later on further complications hepatically. So it's very important to consider that when we're managing people for fatty liver, or MASLD as the technical name for it. It's a huge association with cardiovascular disease. For example, if you've got MASLD, you're about 1.5-fold higher risk of developing new onset heart failure, for example, regardless of the presence of hypertension. You're a higher risk of mortality and morbidity of cardiovascular disease if you've got MASLD. So MASLD is a recognized risk factor for major adverse cardiovascular events leading to mortality and morbidity. That's really important to remember. So seeing somebody with MASLD should instantly make you think like seeing somebody with hypertension or seeing somebody with very high cholesterol. So it means like we need to hit hard here in order to manage the risk of cardiovascular disease in those patients. And the management is around management of obesity, management of diabetes, because diabetes and obesity interplay massively with MASLD, and of course deploying all different risk factor reduction. So this is just like to show you the kind of things we think about. So we want to better control HbA1c. We want to ensure that the patient's urine ACR is not balanced, good control of blood pressure. We need to get lipid lowering therapies. We need to start thinking, should this patient be given GLP-1 agonist, SGLT2 inhibitors, considering a statin? And these are the cases when you refer to hepatology, and apparently coffee is good for you if you've got MASLD, especially if you drink 3 cups a day. Well, I thought that was a good thing. I'm just gonna skim through this because I've got just literally probably 2 minutes to finish this. So SGLT2 inhibitors were really kind of stood out because they are diabetes medicines, but they've got benefit also in terms of cardiovascular outcomes, and they've got different benefits for CKD, and they've got benefits in heart failure, and also they've got some benefit in MASH as well. I'm not going to dwell into too much of these slides, but all I wanted to highlight that about them. The GLP-1 receptor agonists, we'll talk more about them, but basically GLP-1 is a hormone produced in the small intestine, which stimulates insulin secretion and suppresses glucagon release and slows down gastric emptying. It started as a diabetes medicine, but it was found to actually reduce weight. That's because it does more than just that. It actually has an effect on the inflammation that happens in the adipose tissues, reduces inflammation. It has an effect on satiety and feeling full. It has an effect on the heart and cardioprotection. It has effect on the blood vessels. So it's got a mechanism of action beyond just affecting the insulin and the diabetes element, and that's why GLP-1 agonists became basically really important for cardiovascular disease, really important for reducing the burden of cardiovascular disease and also CKD. And these are the different benefits seen with GLP-1 agonists. And weight loss was a big thing, and semaglutide was one of the drugs in this study, but it was interesting that it also, independent of weight loss, it actually benefited reduction of MACE by 20% independent of weight loss as well. So there is definitely weight loss that you can see. There is also benefit in terms of kidney benefit. Then it was used in heart failure, preserved ejection fraction, and there were benefit in the heart failure preserved ejection fraction. There was benefit in patients who in reducing the liver fibrosis and those who progressed to have MASH or NASH. And more and more trials are coming out showing the benefits of GLP-1 agonists in MASH. Tirzepatide, the difference between tirzepatide and GLP-1 agonist is simply that it's affecting 2 hormones, not one. So it's got a dual incretin analog. So what that means, you've got 2 incretins. You've got the GLP-1 which are affected by semaglutide and GLP-1 agonists, and you've got the GIP incretin as well. So tirzepatide basically stimulates both, not just the GLP-1. For that reason, when you give it, you're going to have additional outcomes and effects, and that's why in the studies, when they compared it to semaglutide, this is compared it to semaglutide, comparing it to metformin, SGLT2s. Basically, what we're seeing that it produced much better HbA1c reductions, and also produce much more weight loss. So that's why tirzepatide was a bit more stronger and favored. And of course, it's got other benefits, sleep apnea, and it's got some benefit in MASH. And the most recent thing that has just been talked about 7 days ago, I think, or less, is the new GLP-1 agonist, orforglipron. That's in clinical trials. And basically, the studies are showing that now we've got a pill that you can take once a day, 36 milligrams once a day of this tablet. It seems to reduce the weight by nearly about 7 to 8%. So that's coming through. So that's kind of a super whiz of these three conditions, all these.
Ronnie, have you gone on to mute?
Yes, sorry, thank you. I'll stop there. Sorry, okay. I think I've probably taken a bit of your time.
I think you probably overwhelmed the microphone. Well done to cover all of that information in such a short space of time. And just to remind people that you can go back and look at the recording if you want to look at the detail of any of the slides. I'm going to move us straight on and introduce Helena Gregory. Helena is one of the strategic heads of medicines optimization for North East North Cumbria Integrated Care Board, where she oversees patient safety, analgesia, and the North Cumbria area. Prior to this, she worked for many years in community pharmacy, general practice, education and development, and clinical quality. She's also a NICE medicines and prescribing associate. And there is nobody better placed, I don't think, to take us forward a little bit and talk a little bit more about on this topic. So straight over to you, Helena. We can see your slides. Thank you.
Fabulous, thank you. So again, like Rani, we'll do a little bit of a roller coaster ride. I think we'll focus on the obesity and MASLT aspects of having the conversation. We will be using Slido a couple of times during this for some interaction so that you can have a look at what people in the room are thinking. So please, either on the device that you're on, go to slido.com and enter the number, or you can scan the QR code with a phone. So for each one of these, we'll be having a look at having the conversation with the patient and using GLP-1, which Rani has mentioned there, as a focus throughout in obesity and overweight, in type 2 diabetes and in MASLT, about how we might have that conversation with the patient. So starting with obesity, if you joined us for the last presentation around brief interventions and having a think about lifestyle factors, then you'll know the brief intervention structure and the change structure, and that applies as much with obesity as it does with the exercise topic that we talked about then. It's very much moving from the what's the matter with you, as was mentioned before. People know when they are overweight, people know when they are obese, but actually, how is it affecting them in their lives? How is it affecting their condition? How is it affecting their ability to function? How is it affecting how they feel? And if we can take that jump back to what matters to you, sometimes it's a little bit easier to open what can be a very, very difficult conversation for people about their weight and about how it affects them and what they can do about it, because they know quite often they've been really, really brave with sitting in front of you. So for some people, this might be really straightforward and within their comfort zone, and you can move on straight away and discuss the practicalities with them. You can give them the advice and the assistance. But for others, we might actually have to sit for a moment with the distress of their experience. We might have to acknowledge that it's been really hard for them, especially if they've been brave enough to open up on their journey, and thank them for sharing. So using that brief intervention framework and starting with asking, do they want to discuss this further, this medical condition, and the risk factors within it? So we might be saying to them, do you know what affects cardiovascular disease, type 2 diabetes, etc.? They might say yes, or actually it might be an opportunity, and it might be like, okay, tell me a little bit more about that invitation to discuss further before we jump into giving the advice. And then understanding from that where they are on this change cycle can be really, really helpful. So they might actually be in relapse or pre-contemplation, and actually you might need to just briefly sow the seed with them and move on. So for the conversations where we've got somebody coming in talking about overweight or obesity, then there's just kind of 3 key points to think about. So the first one is, if they come to you with a health problem, address that health problem and address it from the aspect of that health problem before we move on. We want to know what's important to the person, and we want to know how this health problem is affecting their function and their day-to-day, whether they know the risk factors that are within it, because obesity, as has been mentioned, is one of those risk factors. But we don't want to immediately say, oh yes, let's jump on that, and then let's absolutely go down that aspect. And we can do that by, instead of necessarily jumping on and saying, you know, let's remove your weight, reduce your weight. Let's talk about how we can get to that ideal weight. We might want to talk about how we can improve their health, and we might want to talk about how we could reduce that cardiovascular risk instead, and thinking about it from that different aspect. But again, having that conversation gives us that little bit of opportunity just to understand, as we said last time, where somebody is at and whether it's actually safe for us to move forward. And actually to be person first in everything that we do. So thinking about them as a person first, and the obesity is second, or the overweight is second. And some people actually talk about overweight and obesity as a medical condition. So somebody having obesity, as opposed to somebody with it, because it's not something, it's not handbag necessarily that you carry around with you. So do they know what are the things that can make their condition worse? Do they know what are the things that can improve their health? And just those very little invitations gives us the opportunity just to think again about that brief intervention and that change cycle and where we are on that aspect. So for someone, you know, it might be quite simple in terms of the daily function. Can they walk the dog up the hill? Can they play with the grandkids? They might be actually relatively simple things that we really want to help them achieve. But equally, you might be talking to somebody who has got trauma because could they go to the roller coaster with their family last time they went on holiday? Can they go in a gym and feel comfortable about working out without being stared at? Just thinking about some of this actually can just maybe move the conversation a little bit. So before we move on, just to have a look at some of those factors affecting health, I'd just like you very quickly to go to Slido and have a think about what phrases you use in practice to talk to people, just to give people some other ideas. I've given you a few there, but if you just want to start typing into the box, it should come up for you as people start typing. There we are. Well done to the first brave person who put that up. And we can see we've got a couple more folk typing. So it's an opportunity just to share what you use in your practice to talk to people about obesity and overweight. Yeah. Feeling better. They've come to you with something. Yeah. What does it mean to them? Just an opportunity to discuss before we're diving in, getting their understanding of it. And we'll just give it 10 more seconds for a couple more people to pop that in. Yeah, good. Are people aware of the complications? So we're asking them, do they know the risks and the benefits themselves? Okay, have they discussed it with anyone before? Understanding that history. What are their understanding of the risks? There's some really good ideas for you there, folks. I will leave this open so you can carry on typing in. And at the end, when I send the slides out, I will send it with everybody's topics. What would you like to achieve? I love it. Analogies. Fantastic. Good. Brilliant. Thank you for sharing those with us. But health is more complex than we think. So health is not determined by the healthcare that we provide, and it's not necessarily determined by people's choices, because their choices are quite often not their own. So next time we come to the inequalities webinar, we will be having a look at the social and commercial determinants of health, which is a really useful way of looking at it. But this is just a quick visualization that when you're discussing things like weight with patients, how do we adapt our consultation to take it into account? How would it challenge our assumptions around the way we live our lives versus the way the patient might live their lives? So, for example, thinking about the socioeconomic, the physical environment, the exercise, I'm just going to ask you to reflect for a moment. Do people have access to active travel, cycling, walking? Does your clinic provide access to active travel? Have a picture of your clinic. If someone wanted to travel there by bike, what route would they take to get there? Would they feel safe getting there? Do you provide somewhere to lock a bike up? If they wanted to know where to lock their bike up, how would they work that out? Do you advertise it? Because owning a car is quite often income related, and actually their bike might be their way to get about. But equally, it is a health factor and a health behaviour, but impacted by so many things that are outside of that individual's control. So we'll have a quick focus around GLP-1s, which Rani has been through, but I just wanted to, as Rani has said, reflect upon the volume that is coming through now. Some of that is within the NHS, as Rani has said, but a huge amount of it is actually through private providers at the moment. And as I always do for this one, I had a quick look at, let's see if we can find some reliable health information online. The answer was no. This is TikTok at the top here. This is what happens when you type in GLP-1s. Don't, I would say, because you will be flooded with people trying to sell you possibly the drug. Other random things, their experience of it, but actually finding trusted health information to help people make the choice about whether it's right for them and the risks and the benefits. Pretty much nothing. Same on YouTube, we got a bunch of advertisers. So there we go. There is not a huge amount out there. So people may well be coming to you with a few situations that we need to consider as we go through, because they're buying it privately. Providers will vary. So there are risks for people, and obviously if they're acutely ill and coming to you, it's possibly including use for diabetes, around 1 million people in the UK on GLP-1s at the moment, but we don't have information yet for 2025. So you might have people coming into you for adverse effects, whether it's prescribed by you or, as we said, elsewhere. And the information from the MHRA, thousands of people are reporting gastrointestinal effects. That is one of the most common side effects. A lot of reports did not include the drug name and so aren't included in the numbers that you see here. The majority of semaglutide was for people over 50. That reflects its use in diabetes. The majority of tirzepatide was for people around 30, which reflects its use perhaps more widely in weight loss at a younger age. And the majority were female, again, perhaps reflecting the cohorts who were using these. So in terms of the side effects, giving healthy eating advice, the usual fluids, fibre, that should well come from the provider at the outset. But if somebody's coming into us poorly with that, then we might need to check and reinforce that messaging. And it's a really good reason, if you work in general practice, to make sure that you're recording any private provision that you're aware of on the clinical system. And there's advice from NHS England. There's a link at the end to tell you how to do this in case somebody's coming to you. Again, the provider should be giving sick day advice, but we've covered that last time in our heart failure and CKD webinar, so do look back at that if you want to think about what that's given. But there are other aspects as well that we want to be aware of. So the immune response is another quite unusual one with GLP-1s because of the size of the molecule. A quarter to a half of people taking a GLP-1 can get an immune response and anti-drug antibodies. That can be anything from the injection site reaction to lymph nodes, to your fever, to your aches and pains around your body, especially in some of your early doses. And it is rare, but about 2% of people will develop neutralizing antibodies that reduce effectiveness. So it is quite a small number. And we are learning more about the impact on the wider immune responses as trials go through over the years from kind of 2022, and there are additional ones going on today. Just a reminder that if people do come in with side effects, please report it on the yellow card system, and the link is there for you. As you'll have seen, they can be bought on social media, as well as reputable online sellers and local real life sellers. And buying fake medical products, of course, can lead to serious health consequences because you do not know what you're getting. You do not know what the excipients are. You do not know what the equipment is. The money could be ripped off going into money laundering, etc., and enabling crime. So we want to make sure that where people are wanting to buy it, that they're buying through a reputable seller. They can get through various weight loss services. You'll have seen them all advertised before, but if people do want to find a registered pharmacy and it's online, obviously they can go into the high street pharmacy. A lot of these will make them available. There are online services as well, and they should all have a sticker there. But if people are suspecting that they have bought or taken a fake medicine, again, they can do this via the yellow card scheme. And there is a huge amount of activity going through this at the moment. As you can imagine, even just looking back at the social media before, you can see that there are unauthorized sellers who are putting things through. We can have dangerous impurities in medicines, mercury, arsenic, rat poison, cement, anything, so it's really it is very much buyer beware. So there is a lot of advice on the Fake Medicines website and the Yellow Card website, so it is worth a look. But people, again, might be bringing things in, having been poorly, and you might be looking at the packaging, for example, whether things are misspelled, whether they're odd colours, whether it looks of particularly poor quality, whether there's no active ingredients and excipients listed. And again, you can do that report as well as the patient if you wish to do so. And to flag just about reproductive health as well. So again, because people are quite often going to be female, and within those sort of childbearing years, you might get people who are coming to see you about contraception and pregnancy, particularly if they're taking it for weight loss. And this will be an important factor in their lives around their family planning at the moment. So for contraception, individuals using tirzepatide in particular are recommended to switch to a non-oral contraceptive method or add in a barrier method around any dose changes and at a time of initiation. Sorry about that. So there isn't a need to add to a barrier method of contraception when using the other GLP ones. It's just tirzepatide that we're having that. And again, with sick day rules, if people are experiencing diarrhea or vomiting during use of GLP-1 agonists, then they should again follow the recommendations around their missed pills from the Faculty of Sexual and Reproductive Health. No evidence around how it affects emergency contraception, but just as a reminder, the copper coil is the most effective. It's not oral as well. And if someone is planning a pregnancy, then there are washout periods depending on the manufacturer. That can be up to 3 months, which are recommended. There isn't much information at the moment about how it can affect pregnancy. There is limited data at the moment which suggests that there may be some slight issues, but we're not really aware of anything in particular. Further research is needed to provide the evidence around this, and particularly in later pregnancy as well. So at the moment, it is very much a caution. There are unlikely to be any issues, but we do need further research to confirm, and we are aware of how contraception can be affected by tirzepatide in particular, but some of the other GLP ones as well, if somebody is poorly. So just to be aware as well about the risk of obesity in pregnancy, it's all about the risks and benefits, isn't it? And obesity itself, as we know, does have increased risks in pregnancy, but people are not recommended to have calorie deficit diets or weight loss medicines to affect that, because we want to make sure that the child is getting proper nutrition as they are growing. So contraception is likely to be that important conversation. We want to be aware if people are taking GLP-1s or tirzepatide in particular, so that we can give them appropriate advice. But there's not enough information yet to say that it is safe for use during pregnancy. So recommended to stop if possible. But obviously people, again, should be having that conversation with their provider. Now, I'm just going to skip straight across the diabetes section and move on to the MASL section, because I'm just conscious that we've only got 5 minutes left. And I do want to cover liver disease just very briefly. So Rani has covered a bit of information about liver disease and how we might think about the progression with patients. But it can be really confusing for people, because quite often when they're coming to us early and we're picking it up early through screening of, liver enzymes and so on, as part of our routine screening, then actually it might be really early and they haven't got symptoms yet and need to understand what it means for them, and as well the confusing literature and changes of name from the non-alcoholic fatty liver disease. So there is some fantastic information. It is an absolute gold mine. If you have a look on the British Liver Trust, they have a glossary of terms if you need to explain to somebody what something means, if you want to talk about progression, and they have some absolutely brilliant videos and leaflets as well that people can either watch or have a look through. So highly recommend, if you've got people coming into you with MASLT, then do have a look. But talking in practice, we really need to elicit the patient's understanding, because many people in the general public will associate liver failure with excess alcohol or infectious disease such as hepatitis. So we just really want to make sure. Again, I am going to skip over that part, but I just did want to flag that that was something that was really important to us. Now, use of medicines in liver impairment is one of the more complex, unloved and challenging areas to deal with. The mechanisms are often poorly understood. There's not much evidence and advice, and it's really hard to manage in practice when a patient's sat in front of you. I'm no expert, but I've just been really curious when it has happened to me. If you have a look at the BNF, it's really helpful, because there are 6 themes on how liver impairment can affect medicines. In early stages, this might not often show up at all. So it's only later on when people are starting to get symptoms, and it will just throw up a couple of alarm bells for you to be aware of in practice. So the first one is impaired drug metabolism, which is the obvious one for a lot of us. So where the liver is the main route of elimination for drugs, and the hepatic reserve is becoming lower and liver disease is more severe, then this can occur later on. But liver function tests aren't necessarily a really good guide to this happening. Hyperproteinemia is a second one. Again, this is mostly in severe disease, and you'd want to be aware of your steroids, protein-bound drugs such as prednisolone for this one. So that's just one to be conscious of. And reduced clotting, particularly for the older-fashioned anticoagulants. These should be regularly monitored to mitigate, but things like warfarin, it can reduce the hepatic synthesis of the blood clotting factors and have a longer prothrombin time. Hepatic encephalopathy, again in severe disease, being aware that drugs can impair cerebral function and can precipitate hepatic encephalopathy. And these include sedative drugs and opioid analgesics and some diuretics as well. Just being aware that these are often used as part of palliative care. So we just need to be aware where somebody is in palliative care with very end-stage liver disease around the management of their capsular pain around that, particularly things like oxycodone. They may need lower doses or reduced frequency. Fluid overload and edema. Again, this is something with chronic liver disease that we're much more conscious of. NSAIDs and corticosteroids, again, for this one can be issues. And then lastly, in terms of hepatotoxicity, dose-related, unpredictable, just want to be very, very aware of that one. So again, non-steroidals, interestingly also statins and coamoxiclav as an antibiotic are some of the ones. So just having a think about those, because we want to keep taking them quite often for their preventative or their supportive elements. So statins, so we're not necessarily stopping them, but we might want to be monitoring them. And just to finish up, fantastic advice from SPS on this one in carrying out a review. As always, it's personalised care. Start with the patient and then move on to the condition that they've described it, not the list of medicines which you can deal with later. Just have those alarm bells in your mind as you are dealing with it. And if you want information on GLP-1s, if you refer to the NICE type 2 diabetes guideline, they've got a link through as to what to do in liver impairment. As was mentioned, GLP-1s do have a protective effect on liver disease through their effects on metabolism, as Rani has described. Little is known at the moment about the mechanism of action of other parts of the body and how it pans out in practice, and therefore there's very limited information from manufacturers. So most GLP-1s are suitable for use in hepatic impairment. The body's exposure is quite often decreased rather than increased, which is again the opposite to what we'd expect. But there's not enough evidence yet for any dose increase that we might give with them. Lastly, just tirzepatide isn't on the list, but we just want to be aware that there is a risk of metabolic acidosis due to accumulation of benzyl alcohol, which is one of the excipients. So just to be aware of that if you've got severe liver disease. So that has been a very quick run through. Thank you so much, folks, for your time. And I'm sorry that we haven't been able to go through all the interactive sessions as we'd hoped, but it's been grand talking to you. Thank you.
Thanks, Helena. We're just on 1 o'clock, and I have to say, I think that's a phenomenal achievement from both you and Rani to finish at 1 o'clock and cover such a big topic and be so informative. There've been a couple of questions in the chat, and Rani's been working hard whilst Helena was talking. So I'm simply going to let you know about the next webinar in this series. It's on deprivation, gender, age, disabilities and ethnicity, and that's on the 13th of May. So please register for that if you're interested. You can see the previous webinars on the website. And we will be asking for your feedback on this webinar. So please, if you just take a couple of minutes and give us some feedback, we really, really appreciate it and very much welcome that feedback. So thank you to our speakers. Thank you to Sarah for keeping us all on track. She sits in the background, but she absolutely makes sure these sessions run well. And thank you to all of you for joining us and for your participation. Goodbye.